Start. Hello, my name is Kate Bush. I'm the coordinator of programs and services at the ALS Society of Quebec, and it is my great pleasure to welcome Maître Hélène Gay for this webinar today. Maître Gay has been a member of the bar since 1988. She chose to develop a practice in the field of health law and is essentially oriented towards the representation of users of health services and their families. She runs a litigation law firm and represents victims of medical errors or their families, as well as individuals who are the subject of requests relating to their capacity or integrity. She advocates for the respect of people's rights before administrative authorities, and she has developed an expertise in representing seniors and defending their rights. So welcome very much, Mate Gay, to this webinar.
Yes, well, thank you very much, Kate, for inviting me to address this very particular issue of consent to care. And I'm so pleased to again be with you, with your group. And yes, it is nice to see that there are people interested by the topic. I suppose you do, or you may have questions related to the topic, even situations involving yourself or people surrounding you. So my objective with you at this moment is to share with you some thoughts and suggest to you some different questions on the topic. And I will share with you at this moment the presentation. That presentation is really addressed to you as further to the invitation of the society. And I'm most pleased to welcome you after the presentation to address your questions. I believe you can also write them in the chat. That will be, and we'll look into the chat at the end of the presentation so that we can answer them and have a nice discussion. Presentation I have prepared for you is essentially based on the legal aspect and also my experience concerning people affected by ALS. So what I'm going to propose to you is this program, this framework, talking about contextualization. The fundamental rights is inevitable from my point of view. As Kate mentioned to you, I'm practicing lawyer, litigating in matters of integrity and capacity of persons. So therefore, the notion of consent to care needs to be understood, and the notion of care as well. And we cannot escape the substitute consent to care, which is a consent once the person is incapable to consent for herself or himself. And a quick word with regards to medical records and professional secrecy with a conclusion. The presentation will be accessible throughout this presentation. It could also be available as a PDF document if needed or if requested to the society. Contextualization, what do we mean? Well, what we mean is, what do we mean by consent to care? I believe it is important to uh, question us and the notion itself. Why is this notion so important? And who decides when I become incapacitated by reason of a sickness, a deficiency, or even aging? Who decide when I refuse to consent to care? And with regards to consent to care, which is an essential notion in matters of healthcare, expressing wishes and signing in advance directives. What are the differences and how can I protect myself or decide in advance in case of incapacity? So these should be addressed in when we cover this topic. And more fundamentally, we may refer to the very important sections in the civil code with regards to the human body and the person. Nowadays, we're discussing of if you follow the news, we talk a lot about abortion. And we look into the South, what has been decided, and we question would it be the Could it happen that we reverse the decision here that was rendered over 30 years ago? Well, all these issues that we hear from time to time, be it medical assistance, be it abortion, be it end-of-life decision or day-to-day decisions, are based on some fundamental rights. The first ones I would refer to would be that every person is inviolable and is entitled to the integrity of his person. So these are extracts from the Civil Code, and they're applied in any situation that are dealing with integrity of the person. So being inviolable meaning that no one may touch myself or decide that I should be submitted to a treatment or some sort of care without my consent. So this is very strong when the law says no one may be made to undergo care of any nature, and we will look into the nature of care. But no one may means it's an absolute contradiction, absolute measure of no way you're going to be submitting someone under for care without except, and I'm sorry, but the typo, except with his consent. Based on what? Based on the fact that I have control over my body, even though I'm incapacitated physically and even mentally. Every person is fully able to exercise civil rights, meaning that one needs to demonstrate that I'm incapable before saying that I may not exercise my right over my body. I have the right to determine what is best for me and what is not acceptable for me. And I'm presumed to be able to do so, whether I'm 26, 62, 86. I'm presumed, even though I do have a diagnosis, even though my prognosis is bad, I'm presumed to be fully able to exercise my civil rights. And if occurs that the person becomes incapable, and that doesn't mean because I do have a diagnosis of ALS that I become incapable to exercise my civil rights. To the contrary, I'm presumed to be able to exercise my civil rights. But if it comes to the conclusion after evaluation that I'm incapable of giving or refusing consent to care, then a person authorized by law or by protection mandate may do so. Because of what? Because there is a need to obtain a consent from a person before providing care of any nature. Now, all of these human rights of inviolability and capacity and presumption of capacity are enshrined into the Charter of Rights, into the Civil Code. So some of these fundamental rights we may list here because there are more than these. But these are the right to life. So meaning the right to receive care in order to save life. I might want to live even though I'm incapacitated and I do have a tracheostomy or have life support or I have nutritional support. So I do have a right to life. Although I do have one diagnosis, 1, 2, 3, 4 diagnosis, I still have the right to life, the right to dignity. So therefore to continue to receive care in a manner that is respecting my dignity, in a manner that I will live with dignity and die in dignity. The right to integrity is also one, and again, another typo. Well, it should have been reviewed, huh, Kate? I'm sure you understand. I'll make the corrections before you get the PDF. The right to integrity, meaning well, if I have some concerns about my body, about my mind, I have the right to be supported with services in order to be comfortable with myself. So the right to integrity means preserving my capacity, preserving my physical and my emotional condition, means would respond to right to integrity. Right to inviolability, I've mentioned. Right to security, meaning, yes, you need to be provided with services with care regarding hygiene so that one is fully in security. Right to protection and representation, if it comes to the point that the person is totally or partially or incapable to make decisions regarding herself or regarding the administration of his or her finances, then maybe there's a need for protection and representation. And this could also interact with issues or with questions regarding consent to care. Who is going to be the person who will consent to care? Is it going to be the representative named by a judgment or named in a protection mandate, for example? And the right to autonomy I referred to a little bit earlier. So all of these, when we talk about human rights, we say they're fundamental, these ones, because they're in the charter, but it implies in response to the existence of these rights that there is a responsibility, a duty on the part of professionals, on the part of someone else to respond to the respect of these rights. And actually, in matters of consent to care, the duties are on the shoulders of healthcare professionals. They are the ones to obtain the free and informed consent. The free and enlightened consent, we would say. Free and informed consent meaning what? Meaning that before consenting to care, whether it is hygiene care or whether it is intrusive, important intervention, very important care, whatever type of care, health professionals have a duty to obtain consent from the patient himself or herself before performing. So this means what? This means that they have a duty to inform, to give clear, precise, and complete explanations that can be easily understood, clear to the particular issue, precise, so determining what is going to be done, how do we proceed, when it's going to be proceeded with. Complete explanation, meaning that the person has been able to understand, all of the implications. Complete meaning taking the time to explain. So what do we mean? What is this terminology? So that it can be easily understood. What is this term? What you're talking about? So also given the possibility to the person to ask questions. Could you clarify this? Usually we are not knowledgeable of their medical language or all the language that we could use the physiotherapist or the nutritionist. They could refer to some terminology that we're not knowledgeable of. So we, as patients, we should have the possibility to ask questions and in order to be fully informed of what can I expect out of the treatment they are suggesting to me. And so therefore, the professional has this duty to respect the integrity and the inviolability. This is why they need to obtain the free and enlightened consent. They cannot go without obtaining it. They cannot go because, advanced stage of ALS. So therefore, the family is suggesting that we should stop this antibiotic or this particular treatment, or we should add more medication. So no, the important element here to retain is that the informed consent, meaning that informing the patient, advising the patient, and obtaining the consent to care needs also to be free, meaning that it ought to be made after this discussion and after a time where the patient is independent for his or her decision, meaning there's no pressure from professionals, no pressure from family members, there's no pressure from people who would suggest, pretty costly here, or do you think that's the right decision considering your wife is very tired and it's quite a caseload here. This is contrary to obtaining a free consent. It's contrary probably also to some other fundamental rights, like right to dignity. So it's the notion of free means being independent, and although some other people might not be of the same opinion, one is free to decide what is best for him or her. in the situation with the suggestion of a treatment. And in fact, the doctor, I'm giving you the example of the Code of Ethics of Physicians here. Their duty to inform, and then after the information being obtained, I will give my consent or refuse to consent. I need to know what's the nature of the act. Is it a surgical intervention or not? Is it, how long will it last? Okay, what is the nature? What are the benefits? What are the non-benefits if I don't agree to the treatment, if I don't proceed toward the nourishment through a parental option? What are the risks of intrusion? What are the risks of installing a catheter? What are the risks of gavage? What are the risks? How long will it last? What is the gravity of the risks? Because talking about a risk, then I'm going to say, okay, that's 10%. In 10% of the cases, there is infection. In 1% of the cases, there is such and such complications. So the probability of realization. And yet, one is not always, one has its own evolution with a disease, with a syndrome. One doesn't, although on paper it might be one conclusion, in reality, very often professionals say, oh, according to, well, not very often, but it happens that professionals say, oh, according to the records here, to the results of the labs here, I heard that. Oh, well, you shouldn't be alive. Okay, shouldn't be, what does it mean? It means that it's the person first, and the person who, how she feels, how she handles with the diagnosis progressing. So the person himself or herself needs to be evaluated with regards to the risks that will apply to her or his particular situation. It will vary from one to the other because the progression of the disease differs from one to the other, and the way the body reacts differs also. So the risk of the intervention or will be different, although the nature of the act might be the same. And there is always also, we have to remember, there's always therapeutic alternatives. There are, because medicine is an art, and medicine is always improving from year to year. And so therefore, the alternatives are not always suggested to the patient. And we have to call them ask them, tell me, are there alternatives? Why do we recommend this one? Because the professionals tend to decide this would be the solution for my patient. Because I know the patient, I've been seeing him for the past 6, 12 months, and I know where he stands. So I think there's no other alternative. It might be that there is no other alternative from the point of view of the professional, but we ought to be informed about the existing alternatives also. And that should be part of also discussing about the complications during treatment, which should come up as a frank discussion, which should be not hidden. And the courts have said so. So it's not just an idea that we think of, but it's written in the Code of Ethics and the courts have enforced. And so therefore we tend to question, do they have to inform about everything? Well, exactly everything. If the possibility of complication is so low that they may not suggest the complications, or if it is impossible to foresee any difficulty, well, they might say it's impossible and they cannot go on. Well, in this other case, we have seen this other case. So everything, not, but at the minimum that can be understood for the patient who is placed in a similar situation. So if I'm at the very beginning, maybe I want to know a lot. If I'm very much informed, maybe I don't need to know all of this that they're going to tell me because I've read a lot, because I've gotten informed. But if I'm progressing, maybe I need that it be repeated and clarified. And maybe I need to know a little bit more about, oh, the prognosis I wanted to hear about a little bit more. So the information should be understood. To be understood, it needs to be vulgarized. It needs to be clear. It needs to be used also as so that it's providing the patient, the person to come up with, okay, what is best for me? And giving a second thought, okay, what is best for me will be that instead of your recommendation or your recommendation. So it's very important to be given the opportunity to ask questions. And the professionals ought to know, and they know, and there are forms for that, and they know that they need to obtain consent. But part of obtaining consent means also taking into consideration language barriers. Not everyone has a first language English or second language English. It could be a third language English. So that it be understood that there is a language barrier, that their emotions may also bring up some barriers. Uh, be being knowledgeable of a diagnosis for oneself might be initial step as a surprise, as a shock, then after to deal with it, then after to compose and with it. And so there are emotions involved. I might not get all the information at once. I might be at a point in time under medication influence. How does this impact on my capacity to gather the information given and be able to question? So all of this needs to be understood, that one who has a syndrome, a diagnosis, uh, is not at the very beginning an expert, and even down the line might be the expert for his body or her body, but with regards to information, there is always some fragility, and there's no uh, there's no error to consider that we might be at one point less available for obtaining the information. And certainly professionals are being taught, and the courts have said so. Professionals may not just give a brochure to the patient and say, look at this, and this is going to be the information that you ought to know or be given before consenting to. No, that is just not enough, courts have said. So ultimately, decision making is the final decision is for the patient. We ought to, and we tend more and more for the past 40 years, I can say, to have a more of a deliberative model promoted, so that the relationship of confidence is there, but this patient has a say. Patient has a say. Patient is always right, should be considered as always right of making a decision of consent or refusing consent to the proposal of care that's been made. Ultimately, the omission to inform adequately from the health professional might bring this professional to being questioned on his duty to obtain free consent, and therefore it could raise also, and it has from time to time raised and engage professional liability. I want to bring you now to the notion of care. So I don't know if if you have questions, you can put them in the chat for this first part. The notion of care. Why is it important to know? Because the way we divide in our law is the way that we consider what is necessary, what is required by the state of health, what's not required. Why is it interesting? Because what we want is to see if consent ought to be given in writing, if consent is always required, if consent can be given by someone else as the person is not capable to give consent. So I'm going to cover these one after the other. Care required by the state of health, care not required, alienation of a part of the body, and research that may impact on a person's integrity and emergency, of course. So taking one after the other, care required. What do we mean by care required? Well, the objective of the notion of care required is to treat the problem, to treat the condition, to treat the health difficulty attached to the person. So for sure, there is care that ought to be that is deserved to patient with ALS. They will vary through time, and care required involves any care that is necessary for the treatment. Now, treatment might mean getting rid of the infection, getting rid of the fracture. Yes. But it can also mean keeping a level of health that is convenient, reasonable for the person, because the scientists, the medical community doesn't have the tool to treat completely, to get rid of the disease. So treatment is seen as care. The notion of care is when we have defined as very extensive. It involves any treatment, any evaluation, anything that has some link with the notion of care. So it's very large, the notion of care. The notion of care required addresses any care that is meant to treat. Would it be medication to calm down anxiety, medication to treat an infection, medication to treat another disease, or responding to ALS situation. Surgical intervention means any type of surgery that is necessary. Would be invasive, very invasive, or less invasive. They can be under full anesthesia, general anesthesia, or local anesthesia. So surgical is also very vast in terms of what sort of care. All procedures that are diagnostic procedures are also considered care required. So blood tests, scans, x-rays, all of these RM, MRI, are considered diagnostic procedures. They are considered within care required. Specialty follow-up, whether it is nutritionist, whether it is physiotherapy, ophthalmology, audiology, all of these are specialty in the specialty follow-up. Blood transfusion goes without saying, it's care required. Dialysis is the same. So consent may be given verbally for some of these, especially when one is in a long-term care institution. There is signature at the beginning. Yes, I agree with receiving the care. But for particular care, such as surgical intervention, we might want to obtain the written consent of the person. There are other types, such as care and services given at home. They're required. You need to provide with health and social services that are necessary to the person, provide with the equipment, provide with appropriate lodging at one point in time, because staying at home is not possible anymore because of the availability of persons, of caregivers, because of availability of equipment, because of the state health that deteriorates and unable with the environment to respond. So lodging becomes a situation of care required by the state of health. Hygiene care is necessarily care required. Palliative care, although we tend to think it's end-of-life care, not necessarily. Palliative care means, and I recall a discussion I had with a presentation last week at Sutton, Eastern Townships. Palliative care means palliate the suffering. So palliate the suffering. So palliative care need not be exclusively in the situation of end of life, but it will. It might be also an end of life care. We have a specific law dealing with end of life care, and it imposes on professionals to ensure that everyone is entitled to end of life care, meaning that if I would like to opt for palliative care, I have the right to have access to palliative care. If I have decided advanced medical directives, this is also part of end of life care and ought to be respected when applied in this situation where I would have lost my capacity to decide, not before. As long as I have my capacity to decide care, I'm the one to decide. Also, cardiorespiratory resuscitation is one care required, and nutrition hydration as well. So I might decide in advance in case of incapacity, but as long as I'm capable, I'm the one who's going to decide whether I agree or disagree to this care. And we will come back to this notion of agree, meaning consenting or refusing to consent later on. The other categories of care. Well, there's this next category of care not required by the state of health. I'm giving you an example because nowadays we see an extraordinary race in with aesthetic treatment, aesthetic care. The objective is not to treat. The objective is to improve, or to prevent, or to foresee. So screening for disease and predisposition, vaccination, immunization, meaning that going to prevent. And of course, aesthetic is an important one. So consent must be in writing all the time for these type of care. Alienation of a body part, meaning, okay, I'm going to donate my organs, either while I'm alive or upon my death. So what is the objective? Is permitting a person to decide that some of his or her body part will benefit other people in the society. What is the objective? Is really not to treat myself or my condition, but to enable someone else to benefit from. So the conditions will vary whether it is during lifetime or after death. During lifetime, it needs to be that the person firstly is capable to donate blood or urine or this sort of regeneration body parts, or also part of a body that would not regenerate, such as a kidney. The condition is what? We need to, the law sets that the risks shall be less than the benefits brought to the person who is giving away part of the body that is for regeneration or not for regeneration. These are exceptional situations of giving away for say, kidney or part of the liver, exceptional. But the question we can raise is, when the person is incapacitated to decide, who may decide? So there is going to be a representative, but the body part must be susceptible of regeneration. So therefore, the person incapable to consent to care will need to be represented, but only the part of the body that is susceptible of regeneration could be given. So for example, blood. So consent must always be in writing. And after death, what we have at this moment, we can sign our medical card to say, yes, I agree to give my organs and body parts upon my death. After death, you may take all that is possible and give away. Now, there is a project, a bill that's been presented last year, discussed last January, intending to change the notion of consent to donation after death. Consent, instead of being positive, in other words, instead of signing the card, would be presumed. So we would be presumed after our death to donate our organs. This hasn't come into force, but it's a presumed consent, which is something we don't know in our Quebec law, which is exceptional, which exists in some other jurisdiction, that would come into force. So that's a legislative proposal that you may be interested in following. In any case, the consent must be given in writing, but after death, the consent could also be made by representatives if there was no, at this moment, if there was no consent to donation. Research, that's the fourth element, the fourth subdivision of the notion of care. Research is also situated into the notion of care. The objective is what? Is to participate and give time and give knowledge to the scientific community in order to improve knowledge, in order to improve treatment. So one has to remember that there's never an obligation to participate in a research. The conditions to participate in a research are as following: the person needs to be capable, but needs to understand capable to understand what are the risks, what are the benefits, and the risks must be less than the benefits brought to the person's health, and the project needs to be approved by an ethics committee. If the person would be incapable to consent to care, then the person representative could accept that the research be conducted that may impact the person's integrity, as long as it brings some benefit for people in a similar situation. So, for example, I'm suggested to participate at the Montreal Neurological Institute to participate in a research. And the neurologist says, well, yes, that research is really meant to improve our knowledge on the pain suffered, its intensity, the duration, how is this new medication responding to palliate to the pain. So and I feel like I do want to participate, and there are many conditions that ought to be reviewed by the researcher, by the person who is accepting to participate. And consent must always be in writing. But say at one point in time, the person is advanced in the disease and therefore is unable to consent, then the representative could consent, as long as, this is exceptional, as long as the research is affecting or is addressing people in a similar situation, so having the same disease. Very interesting to see that there is research, there is a need for research, so one may participate, and again, there's no obligation to participate in the research. Emergency, very quickly, the objective is what? Is to respond to the needs of a person's life and integrity. When there is danger, such as an accident that is compromising or putting in grave danger the integrity, or one other clear example is lack of rather infarct, cardio infarct, then there is a need to act immediately. Emergency raises the issue of consent, as long as especially when the person is unable to consent to the care. The law provides with the possibility of people who may consent for the person, but say consent cannot be obtained in time, then the health professionals are entitled to proceed with the care required in case of emergency. We may decide in advance in advance medical directives, for example. I do not want that the resuscitation be done. It's also part of some forms of niveau de soins. This all can be discussed with the professionals and be decided in advance. Okay, in case of cardiac arrest, do not resuscitate. So such cardiac arrest being an emergency. So this also can be set and discussed in advance. But this is submitted to the very important notion of consent to care, and professionals have a duty to respect also and be sure that they have all the information prior to, for example, providing emergency care or not providing emergency care. Distinction should be made also with confinement, because the notion of danger to life is different from the notion of danger to self or to others, which brings at times the person to be under a court demand for confinement or for psychiatric evaluation. If need be, we could discuss this later. And physical and chemical restraints is also another situation where one raises, or health professionals raise emergency matter. Now, I want to bring you also to this very important element of refusal to consent to care. Why I find this important? It's because, again, based on the notion and the principle and the right to inviolability and autonomy of the person, we all are responsible of consenting or not, or refusing to consent to care. So we are able, or we are presumed to be able to consent to care required by the state of health. If I'm having going through the disease, I may be less able to express myself and to discuss at length, but I'm still presumed to accept or not the medication, to accept or not the surgery, although they consider it is essential for me to obtain blood transfusion or to be lodged. I'm still in a situation where I may still be able to refuse to consent to care. When I refuse to consent to care, I might be questioning my capacity to understand the meaning and the objective of the treatment suggested. If the treatment is suggested is care required, such as a medication that is necessary for my well-being or the treatment of the syndrome, or surgery that is necessary to reduce a fracture, blood transfusion that is absolutely necessary, then I might be questioned on my understanding, and therefore I might be subjected to, okay, my health professionals are coming in and making evaluations that consider he's not capable, it doesn't understand what we are, what the objective is, what are the benefits, so therefore questioning may be made over the capacity of the person to consent. And if there is such a conclusion of incapacity to consent to care, then another step can be made. This is called the judicial step, only with regards to care required. It cannot be made to force a person who is capable or even incapable to consent to care to be forced for care not required, for alienation of a body part, or for research. In other words, if I refuse and I'm contested in my capacity to decide and I refuse to participate into the research, or I refuse to say diagnostic procedure for predisposition to a certain disease, and a court cannot force the person. The person cannot be forced to receive the care, cannot be forced to donate blood, even though a family member would be very much interested or very much would benefit very much from this step. And I think I will come back also again to this principle of forcing treatment in case of incapacity. For the time, I'm referring to substitute consent to care from time to time. What do we mean by substitute consent to care? And I insist on the fact that it might never happen that substitute consent to care is necessary, is addressed. It might never will be, because it might be that I'm capable, although I'm incapacitated physically, although I lose capacity to talk, I lose capacity to move, I lose capacity to write. I may still be considered capable to consent to care and not have someone else to consent in place of myself, because substitute means what? It means that someone else is going to consent to care, palliative care, medication, surgical intervention. So meaning that someone else is going to take control over what is good for me, what is better for me. It might happen, but it might never happen before I pass away. So what I want to make sure you understand is substitute consent is required when there are evaluations and when professionals have concluded that the person does not comprehend anymore what is the purpose, what is the need for treatment, what are the benefits for the treatment, what are the consequences of not receiving the treatment. So when it is necessary, only when there are evaluations concluding to incapacity to consent to care. Who may? Well, the law sets that it's firstly husband or wife. So the closer one, the one that's in authority. But above and over these, it could be a tutor or mandatory homologated mandate. So these are in priority to even to the husband or wife. Tutorship, mandate in case of incapacity homologated means one has a judgment given legal status to that person. And then after if there's none of these, then husband or wife. and there's none of these, then a person showing interest or a close family member, that one or the other may be the one who may give substitute consent. And the requirement, I would say the most important requirement is that certainly the person ought to know the person for whom he or she is consenting to care. But what is very important also is that this representative, or the one who is giving substitute consent, has in mind exclusively the best interest of the person. So thinking not what I would decide if I would be in the situation, but what I decide considering the person I'm consenting for or refusing. And so knowing that person, what would be best for that person. And the other next requirement that is important is the fact that the substitute consent giver has to be informed prior to accepting, so consenting or refusing treatment. Be fully informed, the same as we have seen at the very beginning of informed consent, the duties on health professionals. Judicial authorization, I'm coming back again on this. Why do we hear from time to time that there is a judicial authorization for care towards a person? It is exceptional, although there are frequent demands in the courts. I could say that since 1994, where the Court of Appeal rendered judgment, there is a raise every year of the number of judicial authorizations obtained. But the courts have a duty before giving judicial authorization for care to institutions, long-term care institutions, hospitals, etc. They have primarily to consider the fact that there will be an infringement into autonomy, integrity, and violability. The Court of Appeal has repeatedly said so. But at one point in time, there is a need to authorize care based on the same. The fact that we need to improve autonomy of the person, to give precedence to the integrity instead of leaving the person in a situation where she would, her state of health would deteriorate, or she would not be in a situation where the care would not be provided responding to his or her needs. So, but as I said, this is exceptional, and there are conditions before a court authorizes treatment, authorizes care. Firstly, the person shall be objecting categorically. I don't want to be lodged. I do not want to be lodged. I do not want to continue to receive treatment. I want to have access to palliative care. I want to have access to other end-of-life care. So I refuse categorically your proposal of treatment. Categorical refusal in itself is not a big matter, because we are all entitled to, but it's the notion of incapacity of the person to comprehend, to understand what is meant by the treatment. Say, for example, hygiene or antibiotic or lodging. Lodging would certainly be one major situation where the demand to the court would be to force a person to lodging, because it's not possible anymore to have the same person in the same unit in the CHSLD, or to keep the person at home because there's no one else to take care of her, because there's no more caregivers, because the husband or wife has passed away, and so therefore lodging is necessary. Not understanding the benefits of lodging in such a situation would bring a case to court if the person was to oppose categorically, if the person was incapable to understand. Therefore, the authorization could come up from the court and therefore force the person to be lodged. Now I want to address also the issue of access to medical record. All of these different care that I've discussed before, you can imagine, are noted in the medical records. Medical records, the containers of medical records has evolved throughout the years. Before, we had charts. We had the paper charts, paper records. Nowadays, we have less and less paper. We have more and more electronic records. So the content has evolved pretty much. So the container has evolved pretty much. The content has evolved also. The forms are different. The way to chart is different. Um, Nowadays, health professionals chart more by exception. Still, the content should be exhaustive too. For example, obtaining consent of the person shall be described very clearly. Okay, he is decided not to receive any more care, only palliative care, does not want to be resuscitated, wants to have the possibility to have additional meeting to express his decision on the outcome he sees in the coming weeks and months. Wants to continue to obtain treatment because wants to continue to participate in the research, although very limited, although the wife is exhausted, still wants. So this is uh, integrated into the medical record. Health institutions have the duty to constitute and preserve the content of the records. Health records containing confidential information. Confidential because it's attached to the person, because it's given verbally or even non-verbally from the person who is being recorded in a medical record with what is most intimate to the person. The discussion we have with health professionals, we may not have with any other people around us. And these confidences are usually noted. They might not always be, because at times professionals judge, okay, he's telling me how much he loves his daughter, but how much he feels like there is a need to put an end to, or because he loves so much his daughter, there's a need to survive as much as possible because she's pregnant and he wishes to be there present upon the delivery and after to be able to be called a grandfather. So this information is going to be filed into the record, and it is communicated to the health professional um, because of what? Because we are in a relationship that is called therapeutic relation, and we feel like we can tell. We are not able to tell the daughter, but we are able to tell the health professional who is the guardian of professional secrecy. They are the guardian in terms of they have to preserve professional secrecy due to a law enforcement. The law says you have to respect professional secrecy. Whatever you hear, whatever you note by way of what you observe, whatever you're being told, you have to keep secret. These are confidential information. And who may and this is imposed to you because you're taking care of people who deserve respect and who deserve respect of their private life and who deserve respect of the information regarding their health, emotional, physical, and so therefore, and even financial. Uh, so the duty is on the shoulders of professionals. Of course, I may decide that I want to renounce to because I'm the one who is entitled to professional secrecy. They are the ones who have a duty to respect professional secrecy. So I have the right to professional secrecy. I have the right to ensure it is protected and that the professional will not share my thoughts, my emotions, unless I agree to do that he does so or she does so. It's an ongoing obligation on the health professionals. No matter the means, no matter if it's through telehealth, no matters if it's in the office. It belongs to the patient. I may renounce. Yes, I may renounce verbally. I may renounce in writing. I may not renounce. I may say to the country, don't disclose. I don't want my children to have access to this information. It's too confidential between you and me. And I feel like my wife may, but I'm not sure. Let me think about it. I may decide that at one point in time I will be accompanied, and I will be accompanied so that I do renounce, because I invite this person into the meeting. So therefore I do renounce to professional secrecy. I share the information I've been given, and I share the information I gave also. So I should be kept in control of professional secrecy. Of course, it makes sense to be accompanied, but it makes sense also, from depending on one's situation, not to disclose what I feel to be uh, kept between my specialist who's taken care and myself. Um, there are other situations when I may be in situations of renouncing. For example, if I decide to consult another professional, well, the information will be disclosed to this other professional, of course. So, in conclusion, because I'd like to give you some time to for discussion and for questions and for, yes, some thoughts. Consent to care is essential. I hope I have convinced you of this. Um, and why is it essential? It's also based on what I've exposed, but also um, because there are legislative modifications that have come into force that are also supporting the importance of consent to care. Um, in 2020, there has been this new law concerning caregivers, recognizing a legal status to caregivers, an official one. Imperfect in its outcome at this moment. We're still working. I believe it's going to be a work lifetime to address and have this recognition and support of caregivers. But let us remember that there is a law that has been confirming the place of the caregivers into the relationship with health professionals. Assistance for capable adults came into force in November 2022, meaning that I can ask for a person to be recognized as my assistant without me being unable to consent and to decide for myself. So meaning that I would like this caregiver, for example, to be recognized as an assistant, so that assistant and that person is entitled to obtain information and make steps to give information concerning myself. Can be useful. It's not absolutely necessary, but this is a modification important to know of. Advanced medical directives that came into force 10 years ago. Anticipated demands for medical aid in dying, you have followed. Last June, it was adopted already a year ago. This change that has been brought to the Medical Assistance in Dying, End of Life Care Act. And the presumed consent I discussed earlier, and I suggest that this will be also looked into further, probably next fall, with the government, whether they're going to come up with a legislative proposal or not. So, as you see, there's many questions that may be raised from this very important notion of consent to care. There are rights, there are remedies, and in case of doubt, one should certainly consult to ensure that one is respected. So, thank you for your attention, and the floor is yours now.
Thank you very much. That was very informative. Um, uh, we had a question at one point about whether a person has a right to refuse placement, even if the caregiver is burning out. So, what are the possibilities in this type of situation? And then I'll have another question after that.
Yes. What are the possibilities? Well, it sure is a frequent, difficult situation, um, and the law does not solve all these situations. The law doesn't have a magical tool to solve every situation. This is a life decision that is dealing with one person who is in need of care, and one person in possibly not capable anymore to provide care that is required, assistance to the needs, etc. The solution for this is of many folds. Uh, Certainly, there's a need to gather some help from health professionals, gather some help from people outside who could help out in discussing, okay, what are the options we have? What are the pros? What are the cons? What are the benefits? What are the um, difficulties? And facing this is not always easy, neither for the supportive one and the person taken care of. And it might be that the person concerned will never consent to placement. I call lodging. I don't like the word placement. I actually hate the word placement, but I understand what you mean. So um, it might be the person might never be comfortable with this option. Uh, but at one point in time, it might be impossible to stay at home. So facing this and trying to come to a consensus with the person is a challenge. It might take hours, weeks, months, finding alternatives throughout, trying to, because if a court was going to look into the situation, the court would have to conclude first that the person is incapable to comprehend what are the benefits of lodging, the incapacity to comprehend. And usually the person would comprehend what we mean by lodging, why it is necessary in the case. But if the court would come to the conclusion that the person does not comprehend, that it is impossible to stay at home, that it is absolutely necessary to be lodged because there's a need for care 20 out of 24 hours a day, because there's no one else that can take care of the person. So um, going the way of concluding to incapacity to consent to care will be necessary if we want to force lodging. This is certainly hurting the person concerned because no one wants to be declared incapable to consent to care or incapable to make decisions. But it could be the ultimate step. In the meanwhile, finding alternatives for services at home is one step that the social worker could support and other people, professionals could help for solving the situation.
Thank you.
Does this understand? Does this make sense? Does it answer?
Yes, it does answer. Yeah, thank you. In another situation, a caregiver, we were told that a caregiver cannot legally leave a vulnerable person without adequate care. Is that correct?
Well, um, certainly this duty not to leave and not to uh, put out on the street a person who's in need of care and not to transfer a person to long-term care without authorization is certainly a duty on health professionals. We are by law obliged to bring assistance to a person whose life is in danger. Is the caregiver obliged to provide the services? There's no legal duty enshrined into the charter, enshrined into the law that imposes on the caregiver to provide services to the person concerned. There is a moral obligation, certainly, to support the husband, the wife, the child, the daughter. Yes. But would a caregiver step away and the complications happen? One could think of, well, it was her or his responsibility to ensure to be replaced, to ensure that there is a step being made, that there is a step to answer to the needs of the person. leaving someone who's dependent with a tracheostomy at home without help, without care, um, would certainly raise serious questions on your responsibility towards the life of that person. What did you do? How come? So there is no, could there be measures taken against the caregiver? I haven't seen it so far.
Okay.
In the court decisions, but it does raise real concerns on the caregiver. There is a need to find an alternative. I've seen, for many years, I've heard caregivers saying, I cannot do it anymore, Maggie. I need the CLSC to come over. They're not providing me with enough hours. I need more hours. There's more respite services nowadays than there was 20 years ago. Families are smaller. Families do not always take the lead to support and to give respite to the caregiver. There are at times difficulties to understand the needs of the person when the the husband or wife has been providing the help for for a few years. It's a need for the caregiver to be relieved, and there are families who are taking turns, children taking the turns for the wife, who has been taken care of 24/7. There are possibilities. One has to be creative and push as much as possible the CLSC, the director, the social worker, in order to that they assess really clearly that it's becoming impossible. No more possible. And even the person concerned. So meetings, writings, periodic recalls of this is dressing the list of the facts, the pros, the cons, the impossibility, etc. Document this and ultimately consulting and
Okay.
ultimately making it sure that there could be legal steps if need be.
Okay. Thank you. Can you talk a bit about the right to withdraw consent? For example, if someone decides to opt out of certain care, can they then change their mind and
Yes,
receive or not? Yes.
yes, at all times,
Okay.
as long as you're capable. Give a comparison that is not ideal but is clear. Say I have a diagnosis of breast cancer and I've gone through treatment, and after 3 sessions of treatment, I feel like this is enough. And although I'm 44 years old and I have 4 kids, I feel that's enough. I really want to stop. I had accepted at the beginning, then I stopped. I'm fully capable. I understand the consequences. It might be that I have a life expectancy of 4 months. I know what it means, and I know the consequences for my loved ones, etc. So I may at all times decide, as long as I have all my capacity to consent, I have all my capacity to withdraw, to refuse to continue treatment, also to refuse to withdraw from treatment. There might be consequences of withdrawing some treatments. There might be pain attached to stopping some treatment. There might be um, physical consequences such as spasm or whatever. So this needs also to be addressed by health professionals. They should provide that there be no such negative consequences to withdrawing treatment. So before this withdrawing, it's certainly a good point to be informed of what would be the consequences of stopping.
Mhm.
How much time would what would I expect? What would be the possible complications or secondary effects? And what would you provide me with? And what would I expect in terms of prognosis, etc.?
Okay. Thank you very much. I have no other questions. Yes, we do. Thank you, Dale. On your final slide, are there forms to be filled out for the caregiver and assistance for capable adults?
Caregivers, you need not fill a form. There are forms recognizing caregivers. CNESST has one. There are other forms. What the form permits is a clear recognition that signed by a doctor. Yes, this or a health professional. Yes, this person if a caregiver is a caregiver to that person. So it enables to show this form. It's like, hey, I'm a caregiver, so therefore give me the possibility to have this holiday, this being paid, although I'm absent that many days because I'm a caregiver. So we need to address in each situation if there is this sort of right to be, say you're at work and you have an employer and you show this, whether it's going to. So the idea is to the form will formalize, but the law does not impose that there be a form. And the notion of caregiver is very, very wide. It can be temporarily, it can be on a periodic basis, it can be on a non-periodic basis. It's very large. So there's no particular form. Assistance for capable adults means that there is a process to go through, very heavy process, meaning that the assistant with the person asking for this assistant to be recognized need to go through an evaluation of their relation and demand and so the request and their objective. And there is a full inquiry on the assistant. A full inquiry, meaning even a police inquiry.
Okay. Thank you. I don't see any more questions. So I'm going to say thank you very much for your presentation, Maître Gay. It's always a pleasure to have you with us. And I hope everybody has a wonderful afternoon today. Thank you very much.
You're very welcome.